Welcome. This training is for the team members who give hands-on care to residents living with Alzheimer's disease and related disorders. Over the next several lessons, you'll learn to read dementia behaviors as communication, to give personal care that protects dignity and safety, to build a calm and therapeutic environment, to partner with families, to care for yourself, and to make the everyday ethical choices that good dementia care asks of us. Alzheimer's disease is the most common cause of dementia, but it is never the whole story. Every resident is an individual with a history and a dignity that the disease does not erase. Dementia is progressive, so abilities change and our care changes with them. Other causes include vascular dementia, Lewy body, and frontotemporal dementia, and some residents also have complex medical needs. Always, care is delivered within the resident's care plan. Dementia behaviors change by stage. Early on, you'll see forgetfulness, repeated questions, and withdrawal. In the middle stage, agitation, wandering, suspicion, resistance to care, and sundowning. In the late stage, speech becomes very limited. Residents need total care, and distress may have no words. Through all of it, remember, behavior is communication. It tells us about an unmet need. It is never simply bad behavior. Behavior is communication, and the ABC model helps us decode it. A is the antecedent, what happened just before. B is the behavior itself. C is the consequence, what happened after, and whether our response helped. Use it to find the trigger, then change the antecedent. When Mr. Alvarez became combative during bathing, the team found the cause was a cold, noisy shower room. They warmed it and slowed down, and the combativeness stopped. Difficult behavior usually has a trigger. The big ones are overstimulation, noise, crowds, shift change bustle, pain or an unmet need like hunger, toileting, or fatigue, unfamiliar staff or rushed care, and loss of routine, including being moved. When you learn a resident's triggers, you can adjust the environment and your approach and head off the behavior before it begins. When a resident starts to get upset, your calm is the strongest tool you have. Approach from the front, make eye contact, and use their name. Keep your sentences short and give one step at a time. Validate the feeling instead of correcting the facts. The emotion is real even when the story isn't. Redirect to something calming, and if you need to, give space and try again later. Sometimes a resident becomes aggressive, and your first job is safety, for the resident, for others, and for you. Keep a safe distance, remove the trigger or the audience, and stay calm. Then report and document per the care plan. When a resident raised a fist as a team member reached in without warning, the team member simply stepped back, lowered their voice, and explained each step first. The resident settled. Space and a warning made the care feel safe again. Restraints, physical or chemical, are a last resort and tightly regulated because they cause injury, decline, and loss of dignity. Before anyone considers one, try comfort, pain relief, toileting, food or drink, familiar items, and activity, and adjust the environment. Most behavior that looks like it needs a restraint is really an unmet need waiting to be met. A restraint is never for staff convenience. Helping with daily living is where dignity is either protected or lost. We support what the resident can still do, match to the stage. Early on, cue and supervise. In the middle stage, break tasks into simple steps and use hand-over-hand guidance. In the late stage, give full assistance with comfort and dignity. And always, at every stage, follow the resident's care plan. Dressing and grooming are personal, and patience turns them into moments of dignity. Lay out clothing in the order it goes on. Offer simple either-or choices, like the blue blouse or the green one. Use easy-on clothing, keep the resident's own routines, and allow plenty of time. Praise the effort, not just the result. Never choose for someone without asking, and never skip grooming just to save time. Mealtime works best when it's calm. Reduce distractions and offer one food at a time. Use contrasting plates so food stands out, and offer finger foods when utensils get difficult. Watch closely for trouble swallowing. Follow the prescribed diet and texture order exactly, and monitor for choking throughout the meal. Swallowing problems are a safety issue. Coughing, a wet voice, or pocketing food should be reported right away. Bathing is one of the most common triggers for distress because being undressed and washed can feel cold, exposing, and rushed. So keep the room warm and private, and keep the resident covered. Explain each step before you do it. Protect modesty and stay calm and unhurried. Let the resident help where they can. Watch for signs of distress and be ready to pause. How we bathe matters as much as the bath itself. Toileting touches dignity more than almost anything else. Scheduled toileting prevents accidents before they happen. Always protect dignity with privacy and gentle language, and never shame a resident for an accident. Watch for the cues that someone needs to go: restlessness, pacing, tugging at clothing, and respond. And give good skin and continence care, because moisture and friction cause skin breakdown. Meaningful activity is therapy, not a frill. Engagement reduces agitation, boredom, and depression, and it supports a resident's identity and remaining abilities. The best activities are failure-free, things a resident can't get wrong, because they build calm and confidence, and we match the activity to ability, not to age. Often, the right activity at the right moment prevents a behavior before it starts. Group activities build connection and lift a whole room. The favorites are music and singing. Familiar songs reach people even in later stages, plus simple seated exercise, reminiscence, and themed conversation, and seasonal or cultural celebrations. One caution: keep groups small for residents who overstimulate easily, so a crowded, noisy activity doesn't become a trigger instead of a comfort. Some residents do best one-to-one, with a familiar task tied to who they've always been. Think folding, sorting, or gardening. Sensory comfort like textures, a hand massage, or favorite music, and simple one-to-one attention. When a restless retired seamstress was given fabric squares to fold and sort, she became calm and engaged. The task spoke her language. Know the person and you'll find the activity. Dementia care is demanding work, and the stress is real. It's physical, emotional, and financial, and when it goes unmanaged, it leads to burnout and to errors that put residents at risk. So remember this: self-care is not selfish, it's part of resident care. A rested, supported team member gives safer, kinder care than an exhausted one. Stress builds quietly, so learn its signs. Exhaustion that sleep doesn't fix, irritability, trouble sleeping, feeling overwhelmed or strangely numb, and physical symptoms like headaches or getting sick often. Notice these in yourself and watch for them in your coworkers. A quiet check-in with someone who's struggling can change their whole week. You can't pour from an empty cup. Take your breaks and truly step away. Ask for help and use the resources available to you. Set realistic expectations. No one does this perfectly. And lean on your team and employee assistance programs. The Caregiver Bill of Rights says it plainly: you have the right to care for yourself without guilt. Asking for help is a strength, never a weakness. Families travel this road too, and their worries change by stage. Early on, fear, denial, and many questions. In the middle stage, guilt and grief as abilities decline. In the late stage, end-of-life concerns. Many families feel guilty about moving a loved one into assisted living. A few reassuring words that they made a loving choice, that their loved one is safe, can mean a great deal. Dementia asks families to grieve someone who is still alive. We call this ambiguous loss, and it's one of the hardest kinds of grief there is. It repeats with each new decline. Your role isn't to fix it, it's to listen without judgment and to connect families to social services and support groups. Sometimes simply being present and letting a family member talk is the most helpful thing you can do. Families want to help but often don't know how. Invite them to share the resident's history and preferences. They're the experts on their loved one. Suggest meaningful visits. Bring familiar music, look at photos together, help at a meal, and route clinical questions to the nurse. When one daughter felt useless, a team member suggested she bring her mother's favorite music and help at mealtimes, and the visits became calmer and far more meaningful for them both. A therapeutic environment is a way of being together. The community should feel calm, safe, and home-like, with the person at the center. That means less noise, less clutter, and less confusion, and care that's person-centered. Here's the key: every team member shapes the environment. The calm you carry into a room, your pace, your voice, your presence, is part of the therapy. Small physical details make a big difference for a confused mind. Aim for good, even lighting and reduce glare, which can frighten and confuse. Use clear signage and contrasting colors to help with orientation. Provide quiet spaces and safe, uncluttered places to walk, and keep familiar furnishings around. When the environment is easy to read, residents are calmer, steadier, and more independent. Wandering is common in dementia, and it isn't bad behavior. It often meets a real need to move or to search, so we plan for it rather than punish it. Provide safe walking paths and supervision. Know which residents are at risk for elopement. that's leaving unsafely, and keep exits monitored per policy with the alarms working. The goal is freedom to move within a space that stays safe. Technology can extend our eyes and ears, door alarms and secured access where appropriate, wander management and locating systems like wearable alerts, and bed or chair alarms used within the restraint rules. But hear this clearly: technology supports supervision, it does not replace it. A silent alarm or a dead battery protects no one, so human attention still matters most. Elopement, a resident leaving unsafely, is an emergency, and the worst thing you can do is wait. Act immediately. Alert the nurse on duty or your supervisor, and follow the emergency plan. Search your assigned areas and account for the exits. When a team member found a resident missing from the dining room, she alerted the nurse at once, and the plan was activated immediately. Never wait. Every minute matters, and everyone has a role. Predictability is comforting when memory is failing. Consistent routines lower anxiety, and familiar caregivers build trust over time. Hand off the key information at shift change so care stays seamless, because calm, predictable days are themselves therapeutic. Your steadiness, the same gentle approach, the same reliable presence, is part of what keeps a resident calm from one day to the next. Good dementia care rests on a few simple ethical principles. Autonomy means respecting the resident's choices and voice. Beneficence means acting in their best interest and doing no harm. Justice means treating every resident fairly and equally. And underneath all three is dignity, the belief that every resident matters, no matter how advanced their disease. Dignity underlies every decision we make. Respecting autonomy doesn't end when memory fades. Offer choices even when ability is limited. Honor preferences and advance directives, and balance independence with safety, leaning toward the least restrictive option. Include the resident in the everyday decisions. When a resident refused a shower, the team didn't force it. They offered it later with a caregiver she preferred, and she accepted. Patients honored her choice and still got the care done. Beneficence means actively choosing what's good for the resident and protecting them from harm. Choose the least restrictive, most comforting option. Report changes in condition or behavior promptly, and protect residents from neglect and abuse. If you see something, say something. Comfort and safety guide every choice. Sometimes doing no harm means doing less. Sometimes it means speaking up quickly when something is wrong. Justice means every resident gets fair, respectful care, the quiet ones and the demanding ones alike. Give equal attention and respect to everyone, and don't let bias affect care. Advocate for the residents who can't speak for themselves, and report concerns through the proper channels. The residents who are hardest to care for are often the ones who need our fairness the most, and justice means they get it anyway. Let's put it all together. See the person, not the behavior. Respond to needs and protect dignity and safety. Build calm routines and a therapeutic environment. Partner with families, and care for yourself and your team. Do these things day after day, and you give residents living with dementia what they need most: to be known, kept safe, and treated with dignity. This has been a Palace University training. Thank you for the care you give.